Hi everyone. I would like to start by thanking Dental XP for inviting me to give this presentation about peri-implantitis. I am Edgar Elchar, the director of the Advanced Education Program in Periodontics in the Department of Periodontics and Dental Implant at New York University College of Dentistry. In 1997, after I finished my training in periodontics, I had the opportunity to be hired at continuing dental education at NYU to fix what we called back then infections around dental implant. Those implants were all HA implants. We were not trained, nor have we had any knowledge of what to do in these circumstances. So historically, dental implants, when they presented themselves or when they were brought to North America in mid-80s, those implants were all turned surfaces, or what commonly known polished surfaces. Implant treatment was supposed to be for fully edentulous patients with hybrid restoration made of acrylic denture teeth. It is not until late 80s, early 90s that things have changed. New frontiers have been achieved in implant dentistry. What I mean by that is mixing natural dentition with implants, meaning treating partially edentulous patients. And when we mix with implants next to a natural dentition, some of these cases have had or will have periodontal diseases, will increase probably the probability of having peri-implantitis. The rough surface, which was the first one, HA, just came about in 1988, and it was commonly used in California, and all of a sudden we started seeing reports about an infection of some sort around an implant leading to a tremendous amount of bone loss. So again, what was the cause of peri-implantitis, or what we call it right now, peri-implantitis? So before we get to that, I asked my residents to do a search, a PubMed search, to talk about or to see how many cases have been or articles have been published in that regard. And if you see on that graph that they gathered together, we have had an exponential increase of the amount of publications on that subject from late 80s till the present. So we have also conferences and symposiums dedicated for that matter, for that subject. And so the problem of peri-implantitis has become something of importance in our life right now, and that's why it's becoming so important to understand it. But the problem is, what is peri-implantitis? And that is the big question that we have. Before I start to that, again, I would like to start with you with some cases to show you the importance of diagnosing the changes early to reduce the amount of failure that we can have later on. Look at this case. In 2008, an implant was placed, and as you can see, at the time of restoration, some bone loss was started to take place on the mesial of that implant. And later on, that loss of bone have been left alone, and it progressed further and further. So by the time they referred me that case, you can see the abundance of purulence and edematous tissue and inflamed tissue around that implant. When I open the flap, you can see the amount of bone loss that we have on the buccal as well as on the lingual. We can see it later on. And the loss of bone vertically over half of the length of the implant. And the implant was explanted in that case, and you can see also the damage that it caused on the lingual by resorbing the whole lingual plate. I will show you later on how I treated this case. Or this case that can be very simple and benign, 5 implants with an overdenture bar, and you can see that the plaque that accumulated on those implants on the right side, and you can see that this plaque, when it presented to me, it presented with a sublingual, led to a sublingual infection. And when I took a cone beam and looking at the panoramic view of that cone beam, you can see the amount of damage on the left side. And when we look at the crosscut, what started to be a plaque accumulation led to a complete destruction of the lingual plate and leading to an infection of the sublingual spaces. So this can turn into a serious matter. So again, what is peri-implantitis? That is the big question. Is it infectious disease? Is it due to implant design? Is it due to failed treatment planning? So before we get into those details, we have to work our way through it, and that's what I want to share with you, my almost 20 years of experience in peri-implantitis. But let me start by defining the peri-implant diseases. And I say diseases because there's twofold to that. One is called the mucositis and one is called the peri-implantitis. And when we look at the workshop, the 6th European workshop, when they define the peri-implant mucositis, it says that it's the inflammation in the mucosa surrounding an implant without signs of loss of supporting bone. And when we look at it clinically, you can see the inflamed tissue, edematous, some purulence presence at the neck of the implant, but no sign of bone loss. When we look at the other case, where we call it peri-implantitis, there is signs of loss of supporting bone along with the inflammation that took place. You have an inflamed tissue, purulence, edema, suppuration, and you can see on the X-ray you have also bone loss. So these are the two different diseases that we are dealing with. The question becomes, what's the prevalence of peri-implant mucositis? In the 6th European workshop, they've published a cross-sectional study made mainly, the longest one made, over 10.8 years as a range. You can see it from on 987 implants, it led to 50.6% of mucositis. Now, what does it mean? And it's also very high in the subject. 79.2% of the people having implants, they have presented mucositis. That is a substantial amount. Well, the question is very simple. Like I said before, the history in implant dentistry is important. Now, those implants were only turned surfaces, meaning polished surfaces. They were the protocol, the original protocol. There was no need to have keratinized tissue around an implant. So that's what led to this amount of mucositis, a percentage of mucositis. Now, what is the prevalence of mucositis versus peri-implantitis? And that's Godsland in 2010, in an average of 8.4 years of follow-up of 351 with multiple systems, 4 of them, they found that there is a mucositis in 27.3% of the time, and peri-implantitis is 36.6%. The difference between this and the one previously mentioned, it's the presence of roughened surfaces. So with the advent of the technology that led to roughened surfaces, we have had an increase in peri-implantitis. Same thing we had with HA, now we have multiple surfaces, and now we are having higher risk of peri-implantitis. Until recently, this year, we have had a new publication by Dubar from the University of Washington, where they looked at implant placed by the residents over 5 years. And the interesting part in that study is not only it talked about the prevalence, but also about indicating or predictive factors for peri-implant diseases. And if we look at the breakdown, we have multiple systems. Actually, here we have an abundance of systems. It's like 7 of them. And we have had, in that study, they found out of the 225 implants, they found a survival rate of 91.6%, That's a very respectable number for a training institution. But also they found 33% of mucositis and 16% of peri-implantitis. Again, it's not a controlled environment. It's a training environment, so the maintenances and all of that were not that well followed. But you have a peri-implantitis of 16%. So this is something not to be taken very lightly. But the most interesting part is in their conclusions. In the conclusions that they had, they said that the peri-implantitis is associated with younger ages and with diabetics and with the periodontal status. Well, I don't agree with them on the younger ages. That's surprising. I don't know. I have no explanation for that. But definitely, I understand the diabetic and the periodontal status. That means if they have periodontal disease. The implant loss is also associated with diabetics, immediate implant placement, but also they brought up something very interesting, the larger diameter of implants. And that's something that I cannot understand why the larger diameter implants will lead to more implant loss or to more loss of bone around them. So this is something to be looked at, and hopefully we will have a better look at it in the future. In 2009, I've published a review about peri-implantitis, and I defined the factors leading to peri-implant diseases in 3 categories. One is chronic, one early stages of healing, and the third one iatrogenic. In the chronic, as you can see, again, I said them in 2009 and Dubai recently, history of periodontitis, which is also poor oral hygiene, tobacco smoking, and controlled diabetics. And then I went into the early stages of healing, and you can see the bone topography, meaning what I mean by that is if you have implant that you place in very highly corticated bone and there is not enough marrow, then you're going to have resorption of bone. And the opposite is true. That means you have too much marrow, less cortication. That will lead to crestal resorption. Tissue thickness and keratinization, and in 2015 recently, this fact has been proven by Linkovic. He had published a couple of studies correlating the thickness of tissue around an implant with the early bone loss. Thirdly, the biological width formation, and that is a fact that we have. And then it's the implant design and surfaces. And these are two goes together. Is the platform switching will reduce that crestal bone loss or not? Is the surfaces is the cause? Is the design at the neck is the cause? Again, these things we don't know. In immediate implant, as the protocol started at the beginning, it was to put the biggest implant to obliterate the socket. But one is looking only on the buccal to lingual dimension, but what about the mesial and distal? If you have a very wide implant and you want to try to obliterate the socket, you increasing the size. By increasing the size of that implant, by using a larger diameter, that's what I mean, you are compressing the bone on the proximal, mesially and distally, and that will lead to a resorption of bone, especially in the anterior, with a crestal bone that is very thin, cortical over cortical. And thirdly, the iatrogenic is the poor treatment planning and the excess of cement. So if we put all of these together, by having a marginal bone loss, exposing the roughened surface to the oral environment, we are in a higher chances of peri-implantitis. So if we go ahead and we look at what has been talked about in the literature, recently in 2008, not that recent, but Gemt and Albrechtsen, they said that the etiology of the marginal bone loss around an implant is a multifactorial problem caused by many factors which are not fully understood. And again, I agree with them. That's how I used it in the breakdown in the factors leading to peri-implantitis. So if we start by the concept of biological width of microgap, that is a physiological concept, and we can see that it will lead to peri-implantitis. What I mean by that is it will expose the roughened surface to the element. Now, the theory or the discussion right now is the platform switch is the solution to everything. And you can see that in Europe they took that position that the platform switch is the solution to all our problems. But in reality, there is not enough study to prove it. There's a lot of case reports, but not enough study, as you're going to see with the one that Cochrane has done in 1997, where they defined the presence of biological width around an implant. And this is a concept that took a lot of debate back and forth, but in reality it has been proven. Until we have something like this study to really exclude any doubt that you're going to have platform switch, meaning taking a split mouth, we'll have one side that has no platform switch and one side that has platform switch, and we can see if truly this will lead to a resolution of that or the reduction of that bone loss that takes place when the biological width is forming. So again, I caution you on believing all of these theories that quickly. So we can look at the illustration here, and it can show the presence of the connective tissue, the epithelium, and the sulcus. And if we look at it clinically, this is a case where it was placed and the healing abutment was changed, and then when the crown was placed, you can see that resorption of the bone to accommodate for the biological width formation. What about the access cement? Well, in the access cement, we can see that if we look at clinical cases, it will become a foreign body that will harbor bacteria, and that will lead to inflammation and a resorption of the bone. And this is something, it's becoming a big problem, because most of the restoration nowadays are mainly cemented restoration. And there is a current right now to move back into the screw retain to reduce the amount of excess of cement. But this is something that we need to be aware of. And look, this is another case that shows the same thing. Edematous tissue, very red, inflamed, angry. And when we open the flap, you can see that the cement has seeped through the margins and get stuck onto the surface of the implant. Sometimes it's very hard to detect them radiographically, like you can see in this case where it was on the buccal side. It's very hard to detect those things radiographically. So one has to be very careful when they want to cement the crown around an implant, that to make sure and take every precaution to eliminate the increased risk of excess of cement. For treatment planning, that goes back to the same thing that we were talking before. How far or how close can we get the implants together? How close can we get the implant to a natural tooth? And this is the debate that I was mentioning about, especially, and I was cautioning you about the platform switch. Is it now that norm of 3 millimeter is to be forgotten, and we can put the implants at 2 millimeter next to each other? So this will lead to something like this case. If you look at this case, you have seen that the closeness of the implants together has led to an extensive bone loss and exposing the roughened surface to the element. And by that, when you open clinically, you can see the amount of destruction that this takes. So that is the problem. When an inflammation takes place, you can lead to an extreme amount of bone loss that can be unsaved, other than removing those implants and rebuilding that whole site. Same thing, we did it here with a titanium mesh. And later on, when we expose that case, you can see the bone that we've reformed or we rebuilt, and we've also added some acellular dermal matrix to increase the soft tissue. But look what it took us to correct the defect that should have never been done if the treatment planning was done correctly. And that's why I want to caution you. The norms or the numbers or the distances between implants and distances between implant and natural teeth, they should be, till proven wrong, should be respected. And this is the radiographically to show the progression of that case, how we fixed it from where we started to where we are at that point. Now it gets us to a very important point. How can we diagnose peri-implantitis? And as you're going to notice in that presentation that I'm sharing with you, and I'm not trying to be controversial, but I'm trying to bring out points that they're very important. One is the implant design really the solution? I believe personally that always biology would win. If we understand what we are dealing with, meaning biologically, the norms that we have to follow, meaning if we have bone that, like I said, is completely corticated and we place that implant, we're gonna lose the bone on the crest. It has nothing to do with the implant design. It's the biology. The biology will always win. The second point is the diagnosis of peri-implant diseases. And that is something so, again, still up in the air. Why would I mean by that? Because if you look at most of the studies, this is the most recent one, most recent in 2008, you can see that when they looked at the signs and how they checked for peri-implantitis, they looked at erythema, edema, bleeding upon probing, suppuration, and marginal bone loss. And this is how they defined the differences between both, as we talked about it earlier into the definition of the diseases. But the question becomes, how can we diagnose a peri-implantitis? And if we look at the consensus of ITI, you can see that they've put those as diagnostic parameters: peri-implant probing, bleeding upon probing, suppuration, implant mobility, radiographical bone loss. So, is peri-implant probing correct? Is bleeding upon probing correct? Because we as dentists, we love to probe around natural teeth. That's what we've been trained to do. We love numbers. But is it correct around an implant? These are very important points to be asked. So what is the validity of probing? This is in this illustration that it's going to be in a publication in a chapter of mine. I wanted to correlate for you what is the peri-implant tissue and compare it with the natural teeth. And here you can see that when you have a peri-implant tissue, the peri-implant tissue does not have ligament that insert inside the body of the implant. Rather, when you see it around the tooth, we have the collagen fibers that insert into the cementum, and that will form what we call the basket around an implant. So when you take the probe and you put it inside, basically it's stopped by those ligaments. And that's why if you press too hard on it, then it will blanch and the patient will be in pain. But around an implant, it's different. Those ligaments are not inserted into the body. Now, true, they're talking about roughened surfaces around the neck of the implant, and those roughened surfaces might create this attachment. But how this attachment is? This attachment is not made by collagen fibers, which the sharpest fibers, going inside the body. Rather, it's a connective tissue attachment onto the body of the implant. How strong is that link between them? We don't know yet. But we know that it is different than natural teeth. So if we look at Erickson and Lindy in 1993, they have showed without any doubt that when you take a probe and you put it around a tooth, as exactly what I mentioned before, you can see that fibers that will hold the probe away from the bone. And if you look at it around around an implant, those fibers are not there, and the probe will go all the way up to the bone, 0.2 millimeter. So this is a very important fact, and that fact is still valid till today. And that's why it is very controversial when we talk about probing around an implant. Now, Mombelli in 1997, he looked at the factors influencing probing depth around an implant. The implant and the crown design. Don't forget also, as I mentioned before, implant dentistry has changed a lot. Now we have emergence profiles. In the 90s, there were so much emphasis on emergence profiles, especially it led also into the 2000s. In some companies, if you open their catalogs, you can see the difference of emergence profiles in healing abutment and in prosthetic parts. So the more that emergence profile is big and extensive, the more the probing around an implant is going to increase. Secondly is the inflammation. If you have the tissue that is completely inflamed, there is nothing also to stop that progression of the probe going down inside that sulcus. And thirdly is the force. In natural teeth, when we take the probe and we do an intra-examiner calibration, we always accept plus or minus 1 of differences. How about around implants? So I can't find a better study or better graph than this graph that Mombelli has published in 1997, and it's still true till today because nothing has changed really drastically to make it different. And you can see that around the tooth, when we reach the force of 0.75, you can't force it any deeper because the patient will be in excruciating pain. Actually, this should be within the 25 newtons. So if you look at the implant, it keeps increasing higher and higher the force until you reach to the bone. So now the question becomes, if we are sounding the bone around an implant is different, but if we are in the concept of probing the way we understand it around an implant, like around natural teeth, this is something not accurate. And this is a big debate, and you can see a lot of articles that say, oh, if you take the pocket depth over 4 millimeter or over 6 millimeter, that's what you should be doing. I caution you to be very careful. But I will ask you to be able to read the soft tissue around an implant. If you want to be a good practitioner is reading the tissue around an implant, that will give you a very interesting point of changes. If you see changes, suppuration, inflammation, edema that is taking place along with bone loss, then you should be aware that there is something more happening around an implant. Probing is not an accurate tool to assess around an implant. So how can we manage peri-implantitis? And this is again the biggest debate. So what is the dilemma? Now the dilemma is either we treat or explant. What kind of efficacy and effects on implant surface are we doing? What's the long-term predictability? And the prognosis of implant treated for peri-implantitis. So the goals of the treatment of peri-implant diseases very well defined by Mombelli in 1998, and they still stand till today. It's to decontaminate the implant surface, stop the progression of marginal bone loss, improve the osseous topography around that implant, and hopefully achieve re-osseointegration. And lastly, establish an effective plaque control and maintenance. And these points, if you really memorize them and understand them, you will be able to improve the peri-implant health of your patients. So what are the treatment modalities? The same thing. The concept of peri-implantitis, the whole thing is so controversial. You can see, and you're going to see around my discussion with you, is everybody has their own methods of treatment. The same thing, everybody has their method of diagnosing it. And same thing, people have their own concept of etiology of that. So let's see what are the treatment modalities for peri-implant diseases. Well, you have basically mainly two of them, non-surgical or surgical. And when we look at the non-surgical or surgical, are we going to do mechanical or chemical? And in the non-surgical or in the surgical also. So, and lastly is the resective or regenerative therapy. That's only for the surgical. So if we look at the treatment and we look at the non-surgical or surgical, and both of them, are we using mechanical or chemical? And if we are doing the surgical, are we leading to a resective therapy, meaning osseous recontouring, or we are trying to regenerate the bone around an implant? So let's see how this happens. If we look at the non-surgical versus the surgical, and let's start with the non-surgical. And what we mean by non-surgical, it is same thing in periodontics, is if we curette the tissue or we use antibiotics, either systemic or local, and how would they lead and what's the results? And we look at here in the peri-implant mucositis, they've looked at mechanical debridement. And if we look at all the studies, you can see the therapies, mainly it's either scaling, rubber cap polishing, carbon fibers, and all of these to reduce the amount of scratches on the implant. They said in the result, if you look at all of the review, you can see an improvement of clinical parameters, probing and bleeding upon probing. And this is something what I mentioned to you, that the probing is something that we have to be very careful how we take it as a guide for us, as a parameter. The same thing on bleeding upon probing. So how about the peri-implantitis? And here again, same thing, treatment by curettes. They said that the outcome, and look at it, the pocket depth over or equal to 5 millimeter with loss of over to equal of 1.5 millimeter. So the outcomes are no clinical outcomes and radiographical improvements. No clinical nor radiographical improvement. And Ramvert is the same thing. No improving pocket depths and bacterial load with both therapies. So again, in peri-implantitis, we are looking at something totally different. You can't only do the mechanical debridement. How about the antibiotic addition, especially the local delivery of antibiotics? And here you can see the ones that exist. There was a long time in the late 90s, early 2000s, does not exist anymore. There was something called Acticide, which was a kind of a band, like a cord, like the retraction cord that we used to have a tetracycline. Over time it resorbs and release the tetracycline. And there's the Atridox, which was a chip that you put it in, and Arrestin, which everybody knows about right now. It's the only one that's still in the market. So they try to use putting a local antibiotic into the sulcus of implants. And again, the assessment was based on pocket depth. And again, as I said, pocket depth is not an accurate point in implant dentistry because it differs due to the forces and also the anatomy around an implant. So that's why, yes, there is some resolution in my opinion, but that was resolution of the inflammation around an implant. But is it enough? Because as we noticed before in that one study before, that you need to decontaminate the surfaces, and that's what Mombelli in 1998. Is the decontamination achieved by using a curette and just local antibiotic? And look at what they found, that when you put antibiotic, local delivery, and that's Mombelli showed it in 2001, you have a drop in the bacterial load, but then immediately at the 30 days it goes back up and goes back almost to the same level where it started. And again, Person in 2006 found the same thing, that if you put local antibiotic, it will drop, but it goes back. The bacterial load will goes back to the initial stages where we started. So again, just a adjunctive local therapy and antibiotic with curettes in a peri-implantitis is not going to lead to the resolution of the problem because we are not able to decontaminate the surface of the implant. So how about the systemic antibiotic? The same thing. Again, they assessed them with pocket depths, but mostly they looked at the soft tissue and they had some improvement, but if we go back to the same thing as the earlier one, unless you see an elimination of the bacteria completely, the bacterial or the cause of the bacteria, meaning the foreign body that took place on the implant surfaces, this is only temporary. So it will not stay long, it will reverse because the cause effect of that is still there, has not been removed. So the use of the laser, and the use of the laser is something that a lot of people are talking about. Again, if you want to, they call it lasing the surfaces. You have to basically, I don't know how you can do it non-surgically. Most of the time people are looking at opening the flap and lasing the surfaces. But again, what are we doing with the laser? Are we decontaminating? At what are we decontaminating? And this is something I'm going to show you a little bit later when we look at an SEM and we see the surfaces of an implant when they are contaminated. So if we go to the surgical therapy, the goals are access, assessing the osseous, debridement of the defect, decontaminating of the surface, and then either we do resection or regenerative therapy. And the methods of doing it is open flap, again, either regenerative or resective. But one has to, and I wanted to show you this is a SEM that we took at NYU, and you can see the surfaces of an implant, and you can see the difference of different companies. Each one has this roughened, and if you look at them, you can see that this are open holes that bacteria will fill inside. So how can you, just by doing a local antibiotic or just a little bit of curettage or I don't know, anything that just can decontaminate that surface, unless you mechanically remove it. So this is why the mechanical and the chemical came about. People said, okay, we can do mechanical or we can do chemical. So let's see what's the truth of all of that. If we look at Pilar in 2014, he said the mechanical debridement can be with metallic or non-metallic curettes. Again, they're trying to avoid damaging the implant surfaces. Sonic or ultrasonic scalers with or without plastic tips, a rubber cup with or without flower of pumice, air powder or glycine powder abrasive systems, titanium brushes, and the laser. They call laser as a mechanical debridement. Now it's so it's again they're trying to debride the surface with it, and photodynamic therapy, and lastly implantoplasty. So implantoplasty is just to polish the surfaces of the implant by mechanical means. So if you look at Melardo Valero in 2013, he said the mechanical removal of biofilm from implant surface should be supplemented by chemical decontamination with the surgical access. So that's why let's review the chemical debridement. When we look at the chemical debridement, you have the citric acid, the phosphoric acid, the tetracycline, hydrogen peroxide, chlorhexidine, or saline. And if we look at the citric acid, we can see that the citric acid, which has been used in periodontics also, it will eliminate microorganism and subclinical retained calculus, absence of histologic lesions in gingiva, increase the amount of ions released from implant surface, suppression of fibroblast attachment on implant surface, and difficult clinical application. The last two are the shortcomings of it. How about the phosphoric acid? The phosphoric acid, not much has been talked about in the literature, but what we found in 1984 that it has a comparable clinical and microbial result comparable with the citric acid. And lastly, we found in the most recent one, 1998, I don't know how recent this can be considered, where they took the phosphoric acid and they did it in vitro and in vivo, and they found that on in vitro there was no damage to the titanium surface, and in vivo there was no clinical damage, cleansing efficacy as mechanical debridement. There was some slight pain, but there was a significant reduction into the bacterial load when phosphoric acid was applied. Surgically, if we look at resective or regenerative, and when we look at the resective, there was a study done in 2007. What we mean by the resective, you open the flap, you clean, and you just do a implantoplasty, meaning polishing the surface, and just you do a reshaping of the bone, as we do in periodontics. And they did a test and control. One test that they had implantoplasty, one was no implantoplasty, and both of them has received resective, and the survival was 100% when they did implantoplasty. Definitely they had recession and lower bone level because they did resective, and in control they had again almost the same, but if you see at the pocket depth as they measured was also controversial. They had better adaptation of the soft tissue when they did an implantoplasty. So the conclusion from that article is that definitely if you open and you clean, you need to do an implantoplasty. The regenerative. Now when we talk about regenerative, we look at the type of osseous defect, and that's what we learned in periodontics, and that's what we should be applying in implant dentistry. So when we look at defects, Zitzman 1999 defined the walls, and that's exactly what we learned in periodontics. You need the walls around the defect, or the walls of the defect around an implant. And when we look at the defects, you have multiple walls. You have 3 walls when it's completely contained, 2 walls when we lost some of that wall, and 1 wall when we have nothing other than one wall. And the importance of the wall is not only the containment of the graft, but also to give a blood supply that comes from the marrow of the walls into the bone graft that we are aiming to use, because that's part of the regenerative therapy. So if we look at Chu 2004, so they have always he said that the defect around an implant will be mostly combined defects. They will contain a suprabony and intrabony defect, meaning some walls and some of them are flat, and they will be 55% of the time circumferential, meaning all around the implant. So that means well demarcated, and when you have well demarcated, you are a better chances of success. So when we look at the regenerative, definitely it is the same. You have to use membranes, you have to stabilize the grafting material. We can use both resorbable and non-resorbable, but nowadays you have to use a resorbable membrane. It's safer. And the use of allograft, and again that's something very commonly used in the United States, but probably in Europe they use more bovine bone. So that brings us to the study of Froome and Rosen, and they've had a follow-up of 2 to 7.5 years. And in their protocol was to do a profit jet around the implants and to almost use everything possible in our hands. And again, the assessment was based on pocket depth reduction. So as you can see, the methods was the same, apically positioning, tetracycline, calcium. So again, it's about disinfecting, decontaminating the surface, and putting endogain, Gem21, bone graft, and connective tissue grafts. And so the bone gain was 2 to 9 millimeter assessed on re-evaluation, and they had 40 to 90% of bone gain, which is very substantial. So again, the regenerative therapy right now is gaining a lot of presence. So that means you need to open and you have to decontaminate the surface and to have to graft. So what about the re-osseointegration? The re-osseointegration, the factors that lead to it, it's multifactorial. So if we are opening the implant surface and we are doing implantoplasty, for instance, are we going to have a re-osseointegration? Well, this is something that we don't know, because unless you after you treat, you basically refine the whole implant with the bone surrounding it, you will not know how much reosseointegration has taken place. But if we look at the studies that they have compared the reosseointegration, you can see that you will have a better chances of reosseointegrating roughened surface compared to a turned surfaces. So again, this is something to keep in mind, that if we decontaminate and we will still have a roughened surface, we might have a more reosseointegration with the treatment. And again, you can see another study where they had the same thing, bone graft and decontamination of the surfaces, and they have had some variable chances of reosseointegration, but definitely if they use bone and a barrier, they achieve a higher rate of reosseointegration. So furthermore, more studies also that talks about reosseointegration of the treated surfaces. So there is some hope that when we open and we decontaminate and we do everything that we can, we will achieve some kind of reosseointegration around these implants. Mostly we are turning those implants into health. But that something has been talked about from the beginning of the 90s, that they said if the endotoxin or other contaminant are left on the implant surface, there cannot be biological repair or reosseointegration. So we are still proving the theories that they've been mentioned early in the 90s about the importance of decontamination of the implant surfaces in order for us to achieve a reosseointegration. So what is valid? And these are the questions, we've heard this study has done this study has done that, this one will do connective tissue, bone, just by polishing the surface with saline. Is this true? Or the other one will use citric acid and they wipe the surfaces and they put bone and membrane and they are having a good results. Some others are using lasers. What is true and what is not true? So we went and we did a pilot study where we took implant that they failed, and we've done treatment only chemical, and then we did an implantoplasty. And we looked at the SEM to see if we have been able to remove that or decontaminate the surface by removing that biofilm that takes place over the implants. So this is what we found when we took those failed implants and we scrubbed them with saline, and you can see the amount of biofilm that's still present. And then we did the same thing with chlorhexidine, same story, you can still do biofilm. And now we went ahead and we did the citric acid and the same thing. And those two images that you're seeing, one is closer than the other, and you can see the same thing. On a closer, you can still see the biofilm present, not cleaned. And lastly, we did the phosphoric acid and the same thing. We were not able, by just scrubbing the surfaces, to eliminate that biofilm that took place in between the threads and over the threads. And this is on a higher magnification. So let me repeat the same thing. If the surfaces of the implants are not cleaned up, we will not be able to have a reosseointegration chances or any biological repair. So furthermore, in 2014, prior to chemical decontamination of implant surface, mechanical disruption of biofilm should be performed. So now we know that we have to decontaminate. Now Pilar Valderma is telling us that before you do chemical, you rather have to do some kind of mechanical debridement, because you need to disrupt or eliminate the biofilm. So to go further, we took the second part of those implants and we subjected them to a implantoplasty. Here you can see we took a fine carbide and we just polished the surface of the implant, and we looked at them on SEM. Here it shows you where we did a little bit of the polishing of the surface close to a biofilm, and you can see the difference between a clean surface and the one with the biofilm. And here, on a higher magnification, demarcating the two different zones, one that is cleaned up and one that is polished with by implantoplasty, and one by where the biofilm is still intact. And again, any higher magnification. And you can see how we were able to clean the surface when we did implantoplasty compared to the other surfaces that is still diseased. And that's how it looked on a higher magnification after you clean all of the surface by just polishing them and doing implantoplasty. So the advantages is it facilitates the decontamination by doing an implantoplasty. I mean by that, we are not destroying the surface of the implant, but rather by just reducing the amount of, or cleaning the surface by polishing it. It reduces the plaque adherence to the implant surface, improves clinical and radiographical parameter versus control, and we will have a 100% survival rate versus 87.5 in control after 3 years. And that's what Romeo 2005 and 2007 have said. The disadvantages, and again still to be seen, is the decreased possibility of osseointegration, because you've taken a roughened surface and you turn it into a polished surface. Some people will say that the metal particles are produced by implantoplasty and burrs can be disadvantage to the environment. Again, these are decontaminated. I don't understand why it will create a disadvantage. And they are talking about an increased post-operative recession. That's definitely if you're opening a flap and you are doing only a resective with implantoplasty rather than doing a regenerative therapy. So with that, we will go to the new protocol that we are submitting. And our protocol, or my protocol, is, first of all, if we can remove the restoration, then we can do it. If not, we can leave it. Definitely we will do a surgical approach by opening the flap. We will degranulate the osseous defect, and then we will detoxify the implant surface. And the detoxification that we follow is very simple. We will do an implantoplasty. And what I mean by implantoplasty, we are polishing the surface of the implant. And after we finish that, we take phosphoric acid and we apply it up to 1 minute. And then we will rinse everything copiously with saline to eliminate any residue of phosphoric acid. After that, we will go to the regenerative or the resective. Mostly we will aim for regenerative. And if we notice from the get-go, before we open the flap, that we have a very thin tissue, then we will enhance the soft tissue at that time, and then we will close it. But everything depends on the maintenance. So if we don't follow those patients every 3 months afterwards, we will not achieve a long-term success of these therapies. So that's why the maintenance is extremely of essence. We have to have every 3 months, we have to have a thorough removal of bacterial plaque and calculus, motivate and educate patients regarding oral hygiene, evaluation of the soft and hard tissue around implants, and assess of occlusal force and occlusal stability. This is still debatable, but what's important is to maintain the patient and have a very rigid maintenance recall system. So now it will lead us to a clinical cases. And let me start with case number 1. Case number 1 here, we have a patient that has been treated with a full upper roundhouse of implants, and once 3 years later, he presented with some purulence on that implant in position number 4, and you can see the bone loss that took place. So we had the signs of erythema, edema, purulence, and some oozing of pus, definitely, as we said, the suppuration. So we opened the flap, and you can see the granulomatous tissue around the implant. That granulomatous tissue was debrided, and after debridement of the granulomatous tissue, we can see this is a 1 to 2 walls defect. After the implantoplasty, we laid the phosphoric acid for 1 minute, and we cleaned it copiously with saline. Then we did what we do in periodontics. We used a resorbable membrane, a bone, allograft, and we closed the flap over it. And that is a follow-up of 1 year after treatment. Case number 2, that's the classic look of peri-implantitis, edema, erythema, suppuration, and you can have bone loss around an implant evident on an X-ray. The flap was opened and the surface was polished by implantoplasty, and this is the residue of the metal. Again, I don't see any risk with that. The defect here was circumferential. Basically, we had a wall on the lingual, wall on mesial, wall on the distal, and those were grafted with allograft, and we used here a resorbable pericardium membrane, and I achieved a primary closure. And this is a 2 years follow-up on the right after treatment. And again, you can see the post-treatment X-ray of 19 months. So again, those treatments have been followed, and we have had a good result in stability in long term, but the patient are placed on a very rigid recall system. Case number 3, here we had the patient presented on their maintenance visit. You can see an edema on the soft tissue and some suppuration. So we tracked the defect. You can see it very vividly here that it was a circumferential defect. We opened the flap. We have a buccal plate, and we have loss of the lingual, and we have some proximal. So it was a combination of 2 walls defect, as you can see it here. We did we polished the surface via implantoplasty, and then I placed the allograft and covered it with a pericardium membrane, and the flap was closed. And this is 2.5 year post-op clinical view, and that is the follow-up of 3 years radiograph. As this is the one on the left is after the graft immediately, and this is a 3 years follow-up X-ray. And finally, we'll get us to the last case that I started the presentation with. If you recall, we had that implant that they've missed the bone loss on the mesial, and then it led to that drastic bone loss around it. And as you recall, also when it presented with that suppuration, edema, erythema, and evidence of bone loss, when we opened it, we had nothing to work with, and we did an explant. So I left you on that. So now what I had to do here, we are talking about a vertical augmentation as well as a horizontal augmentation. Here I used a titanium mesh to have really a maintenance of a space and creation of a space, which is a very fundamental cardinal point in bone regeneration. Here I used a recombined human BMP2 infuse along with a combination of cancellous and cortical bone, and laid back that titanium mesh, and I stabilized it. It was stabilized on the lingual with 2 screws, and on the buccal with 2 screws. The use of titanium mesh has been very rewarding for me. I've been using it for the last 7 years, and I have a great results with it. And the two things that I learned with it is you need to stabilize it. It has to be rigid and no movement whatsoever, and always anticipate at the time of the removal to increase your soft tissue, because that soft tissue is going to grow within, and it's going to be thin, and you need to grow that soft tissue upon exposure of the titanium mesh. Sometimes you can remove the titanium mesh, do some kind of an ADM, a cellular dermal matrix, and let the soft tissue heal, and then come back and place an implant. Or sometimes you can put the implant and use an ADM at the same time, or connective tissue for the matter. So here I used an ADM, a cellular dermal matrix. We've placed it and then let it heal, and then 6 months later we removed the titanium mesh, we placed our implant, and because of the positioning, I didn't want to sink it too deep because I don't want to have a long crown. I've added more bone. It's never enough bone in those cases. I used here more cortical at that point, and I put another ADM because you can see the soft tissue is weak, and I closed it and I let it heal, and then this is the result 24 months post-op, post-placement and post-restoration. So again, it's if we follow the norms and we follow everything, we can achieve a good success. But the main thing is to avoid getting to that level. So let me finish my presentation, but what I call Sha'arism, which is taken from my last name. I just try to make a little bit of humor after a whole hour of listening to me. Here in this picture, this is what we call in New York the Flatiron Building. This is one of the emblem of New York. It's every tourist loves it. I am a very big fan. I still, after 22 years of living in New York, I pass by, I take another picture. But if we look at it, how it was built in 1903 by a gentleman, an architect from Holland. And look at it in 1902 or 1903 when they were building it, they were really rudimentary on the things that they were doing. But what they did is they built it on a sound foundation. They built it with meticulousness and with a lot of attention to details. And that's why it is still till today standing, beautiful, attractive, and will sustain forever and ever. And everybody will come, generation after generation will come and admire it because it followed a real foundation, sound foundation. And that's what I try to tell you throughout this presentation, is that biology will always win. If we understand what we are dealing with, we understand how the wound will heal, how is the best placement of an implant, the best environment that we can create for that implant will succeed and will be as beautiful, as nice as this beautiful building that you are watching here on this image. And I would like to end it with that beautiful quote by Steve Jobs. And he said, being the richest man in the cemetery doesn't matter to me, but going to bed at night saying we've done something wonderful, this is what matters to me. And with that, I want to thank you for listening. I want to and thank the family of Dental XP for inviting me, and I hope we get more opportunity to see each other face to face, or also to listen to me through our other presentations. Thank you.